My question is to Rajesh. Rajesh, you mentioned the proximal margin in the GE junction tumors, 2 to 6 centimeters, depending on the the stage, the T stage, right? What about the distal? I mean, because is it standard 5 centimeters, or is that also, because that actually determines how whether you're going to do even the proximal transaction, right? If your conduit is not so long, you don't have the choice of luxury of going up in the proximal margin also. So what are the clear-cut, is there any clear-cut evidence-based recommendations on the distal margin?
Distal margin is...
distal.
Yeah, distal is 5 centimeter is the standard. Standards.
But there's no recent data showing that it's lesser margin.
Mainly the lymphatics, anyway, we have to remove that lesser curvature lymph nodes, so we'll end up in giving a good 5 centimeters margin distally.
Okay. Sir, you also the only hand going up for THE. I know you do a, majority of your work is thoracic approach. Why do you do a THE? When do you do it?
No, my hand went up not because I recommend THE. My hand went up because I realized it's an operation which cannot be consigned to history. Even for, I'm sure Rao will also tell us the same thing, that because we've done so many of these in the past, we know when to do them in the future as a fallback measure in a given patient, in a selected patient, and so on and so forth. Even though all of our teams today recommend we do transthoracic procedures, whether open, robotic, laparoscopic, whatever you want to call it. The problem is that there will be some patients, a few patients, where THE would be a good operation. So a fibrosed lung patient is still all right. You want to do the esophagectomy, but you can't do it transthoracically. You went into the thorax, but you could not complete the operation because the lung is too badly adherent or whatever reason for it. So completing the operation by THE would be a good idea. Issue really is if you don't recommend the operation, then how do the youngsters learn it? And so it's the same thing with lap chole and open chole, that person who has to convert a lap chole doesn't know how to do open chole. So if you have to convert transthoracic procedure into a THE on the operation table, or even before that decide that, okay, today I'll decide that I do a THE, and you have never seen it or done it, then there's a problem. So from that perspective, we'll have to, at least as senior teams, figure out how THE can still be taught as a measure of operation to the youngsters, because it cannot be confined to history, it cannot be thrown away. I know that most of the West has done that, but now, made that base, I still recommend, which Dr. Rao pointed out, transthoracic approaches do what oncologists are supposed to do. See the tumor, make sure you get around the tumor, make sure you have a macroscopically negative margin, make sure you take out all the regional lymph nodes, and do it safely. Can a THE fulfill all these boxes reliably and consistently in all patients? The problem with all these meta-analysis is you put everything into one box and you kind of throw it around and you say, okay, there is no difference. The bottom line is that the data itself was so heterogeneous, the meta-analysis cannot give you a difference. It is the patient profile which determines. So I'm not too sure whether I can say that THE can be thrown away. It's an operation which still needs to be learnt and taught, but should we use it in routine clinical practice in every single patient? I don't think so.
I mean, it's a very important point Sir made about fibrous lungs. Actually, in these 5 years itself, we've had 2 occasions on which we put in a scope into the thorax, and because of the previous some fibrosis, the pleural space could not be developed. But like you said, our problem is we've never had training in the transhiatal esophageal. So in both situations, we actually called a surgeon who can do a transhiatal esophageal and proceeded. Our problem with our generation, it's predominantly lack of, because of blind technique, and unless you're working in a high volume center, we have teachers to continuously teach you and improve your technique is difficult.
Yeah, so I think having done many transhiatals in the training period, and since thoracoscopy developed, we moved on to minimally invasive. But I think transhiatal esophageectomy has a small place in our armamentarium. Especially, see, there are 2 areas. One is that we talk of transhiatal as for esophagus, but I think it's very different for supra, mid-third tumors and the lower third tumors. Transhiatal is a very different operation. Because when you're doing a transhiatal for a G junction tumor, what you are doing, the transhiatal dissection is of the normal esophagus. It's not a tumor esophagus. So the risk of injury to surrounding structures, like Dr. Pratap mentioned, of tracheobronchial or azygos never occurs. Never has, I've never seen it. Versus when we used to do even transhiatal for mid-third tumors also in our many years ago. That is the time when it's a blind procedure. When you're doing it for a normal esophagus, I don't think it's a blind procedure because you can actually have a very good feel of the esophagus. You are very close to the esophagus, so it's not like a blind procedure. It's a very safe procedure for patients who have a poor performance status. And the other advantage is that it's an abdominal-first procedure. You know, if you find peritoneal mets or something, if you're doing a transthoracic esophagus, when you come back to the abdomen for a G-junction tumor, if you see some metastasis, then, you know, you are in a dilemma what to do now. So here it is a abdominal first procedure, and I think that's the advantage of a transhiatal approach.
Thank you. That's exactly was the purpose of my talk also. That THE is not relegated to the museum. It has a role, limited role. It is a good opportunity to learn. And for GE junction, definitely most of the criticisms of a mid-thoracic resection go away because it's no longer, like sir said, it's not a difficult thoracic dissection.
But Partha, you batted so strongly, so all of us also had to have very strong opinions. You spoke well.